Okay, well, thank you very much to the program committee and our moderators for putting the session together. Um, for disclosure, this study was funded and all the data analytics and software were developed by Care Syntax. And this was not a work of just me. This is our long list of contributors that you can see here. So this is based on the push of the American Board of Surgery, amongst others, to go to more competency-based assessments and training. And, this year they came out with the entrustable professional activities units. Everybody knows what they are. Anybody that started using them has had some lukewarm, I think, would be a good way to say it. This is just an example of one of those. And, this is a total of 5 pages long. This is only for inguinal hernia. There is a lot of really, really small font on there. And they have 18 of these, which is about as much as one of those bundles of onions. And there will become more, but you can imagine that trying to read through those and use those in a real world environment would be challenging. So I'm going to base some of this on some work that Dr. Seymour and I did 20 years ago and collected thousands of observations in the operating room. And we came up with some trends from that. And this is going to sort of be the basis for the video assessment. And this is an example of collecting 3 metrics about a global skills rating, operative time, which is very objective, and the amount of the case that was performed independently by the resident. And you can imagine that if the resident was the first assistant only, the case might go pretty quickly, and you might think it's good, and the attending might be want to be popular and say it was the best resident they've ever done anything with, but the independence would be inarguably low. We also saw over the collection of all of this that as the residents gained autonomy, case time went up. And case time went up until case time went down and independence went up. And it was pretty interesting because there seemed to be sort of an inflection point, and that typically happened around the PGY4 level. And to quote the John Deere marketing team, it's not how fast you mow, it's how well you mow fast. And this is really where we're trying to get. Now, looking at global skills ratings, that has some issues. So you could use a video-based assessment. And this is probably the most important part of developing this was the method by which it was developed. It wasn't... It was initially by a couple of surgeons, primarily Bruce Ramshaw, and they iteratively improved it to make it easier to do and effective without necessarily trying to validate anything to the nth degree. And it says that there were 3 of these developed in 24 months. That should say 7 months. So that entire process to make 3 of these with all the software and everything really only took 7 months. And this is just an example of what we use critical view of safety for the laparoscopic cholecystectomy, and everybody kind of knows about that. It was about 5 to 7 minutes to assess each video. And we looked at the global case difficulty, surgical skills, and some of those other questions that were on there, and the details of which are not super important. But this is just an example of what the software looks like. You could go back and forth. You could rate it and do all of this stuff. And then all of the data analytics happened automatically. Here was the number of videos, number of surgeons, how many items were on each thing. And they used a Gwetz AC2 for inter-rater reliability, which is a little bit more robust than in the past. And you can see that it's really highly effective in that way. I mean, the one that's the lowest is the laparoscopic cholecystectomy at 0.55. And we think that that is because there were surgeons across the world doing that had different ideas of how the cholecystectomy should have been done. But that still reached the 0.5 threshold. And so in conclusion, the rapid cycle methodology with iterative improvements, I think, can be used to create and optimize reliable assessment tools. These types of tools can be incorporated into routine clinical care and can be used for trainees and attendings, I think. Ultimately, it would be good to link them to clinical outcomes and financial data to improve quality improvement and total value. And I think that gauging a global community of surgeons is important to get different perspectives. In fact, it's critical. And this can all be contextualized in geographic areas where there is necessarily differences in opinion. Thank you very much for your attention.